Great. Thank you to everybody who's joined. I think we're more or less ready to start now. This webinar had a lot of interest from people, so we expect a large number of people to participate. I can see that people are still joining. However, I'm aware that time is very precious at the moment, so we're going to go ahead and start anyway. We are recording the webinar, so we'll be able to share the recording afterwards with those who are interested. We have a very interesting group of people on the line today to discuss this topic. I'd first of all like to introduce my colleague, Dr. Martin Frieder, who leads the Vaccine Research Unit at WHO, where he provides leadership on WHO's vaccine and immunology research activities, strategies, and priorities. So welcome, Martin. We will hand over to you shortly. We also have on the line Dr. Andreas Gilsdorf, who is a physician with a specialization in infectious disease epidemiology. Dr. Gilsdorf was Deputy Director of the Department of Infectious Disease Epidemiology at the Robert Koch Institute. There, he was responsible for the National Infectious Disease Surveillance System and built and headed the Emergency Operations Center. So we're very thrilled to have you on the line today to enter into the discussion. And next to me here, I also have Dr. Sylvie Briand, who most of you know already as being one of the main faces of the COVID-19 response from WHO's perspective. In addition, we have Andy, who's a little bit camera shy, who's sitting in the north coast of Scotland. Hi, Andy, and he's one of our scientists who has helped to dig into the science behind this topic. So without further ado, we're going to start with a presentation from Martin, who's going to take us through the immunology side of things. Martin, over to you.
Thank you, Sarah. Quick sound check. Can you hear me?
We hear you well.
Okay, perfect. Sarah, are you going to be putting up the slides? Okay, so hello everybody. Today we're going to talk about the immunity to the SARS coronavirus 2 or COVID-19 within the context of immunity passports. So you will have seen that last week we put out some guidance on immunity passports, and we felt that this presentation should guide you into some of the background behind our thinking around the use of these. So can we go to the first slide? Sarah, next slide, please. Thank you. Now, if you participated in the presentations from last week or the week before, you will already have been introduced to the concept of the antibody response and the early antibodies, IgM, which you see in this graph in black, starting on round about day 8, and then the late antibodies, the IgG, which start 1 or 2 days later and shown here in the purple graph. What I'm going to try and do today is to introduce some of the other critical aspects of the immune response, that is the innate immune response, shown in the red line. This begins pretty much day 0, as soon as the virus gets into you. And then also the cellular response, shown in a light green line, which begins, typically we can start measuring it at around about day 6. And I'll try and explain the importance of these immune responses in the body's response to coronaviruses and what we can learn about this in making predictions about protection in the future. Next slide, please. So let's begin with the innate immune response. Now this, as I've already said, is immediate. As soon as the virus enters the body, as soon as it enters a cell in the body, it's going to trigger receptors in these cells, especially if they're cells of the innate immune system. These are dendritic cells, macrophages, and fibroblasts. And when it triggers this receptor, it's going to cause these cells to secrete a range of chemicals. Now, these chemicals are cytokines, but very specifically, the ones that we are interested in are the interferons. Now, interferon, it comes from the word interfere. It interferes with the way the virus is able to replicate in the body. The interferons serve two critical functions. They, first of all, are antiviral. So the interferon will stimulate cells to produce enzymes within their cells that will stop the virus replicating. For the scientists among you, the critical one here is the RNase L, and this will chew up the RNA of the virus that has infected the cell. So this immediate response slows the virus down, and if we are lucky, it will even prevent further infection in the body. Now, there's little asterisks after the word antiviral. And at the bottom of the page, you'll see I've said coronaviruses have mechanisms to bypass this antiviral effect. So most viruses have learned to try and sidestep the innate immune response. Coronaviruses have got a lot of mechanisms that they have evolved to bypass this antiviral effect. But fortunately, as we will see, the antiviral effect does have a critical role to play in our response to coronaviruses. Now, the second role of interferons is to attract and stimulate cells of the adaptive immune system. So we've got the innate immune system, which is immediate and it's independent of the virus. And then there's the adaptive, which is specific to the virus. Now, without the innate response, we don't really get much of an adaptive response. And here, the interferons will serve to stimulate the B cells and make an antibody response to the virus. Now, I want to just mention that the interferons and the other cytokines that are produced also cause fever, muscle ache, etc., which are the early symptoms of infection. Now, the innate immune response normally will subside as soon as the virus starts disappearing. But if the viral infection continues, in other words, if the body is not able to clear the virus, the innate immune response can go out of control. And this will contribute to things you will have heard about, the cytokine storm and the potential pathological response. I also want to mention that older people that are really in what we'll call older adults, may have a weaker innate immune response. And this weak innate immune response allows more virus to get past this first gate, this first barrier. And it also means they will have a slower adaptive response. Next slide, please. Now let's get to the adaptive response. In last week's presentation, you will have learned about the antibodies, the IgMs and the IgGs. Well, there are actually two components to the adaptive response. There's the T cell response, which we'll talk about now, and the B cell response, which makes antibodies. Now, the T cells, what these do is they recognize any cell that is infected with the specific virus, in this case, SARS-CoV-2. And when they see the cell which is infected with the virus, they do several things. First of all, they replicate and they expand. So we start finding more and more of them that are specific for that virus. But there are two types of T cells. There is what we call the CD8 T cell. And the CD8 T cell, its job is to kill the cell in which the virus is multiplying. And if we kill the cell in which the virus is multiplying, well, the virus stops multiplying. And the other type is called the CD4 cell. We're going to call this a helper cell. It helps the B cells make antibodies. It also helps our CD8 cells expand. But it also causes other cells of the immune system to come to the site of infection. So this T cell response is critical. It kills the cells in which the virus is replicating, slowing or stopping the infection, and it helps produce antibodies. Once the virus is gone, these cells decline in number, and we might not easily measure them after a few weeks. But what is important is that some cells will remain. These are called memory cells. And these memory cells will rapidly multiply if they come in contact with the virus again and either kill the virus straight away or accelerate a future antibody response. Next slide, please. And then there's the second part of the adaptive response, which are the B cells, which we spoke about last week. Now, these B cells produce antibodies. Initially, IgM is produced, and this disappears over a period of several weeks. At the same time, or 1 or 2 days later, or 3 days, IgG is produced, and the levels of these antibodies, we refer to it as titer. These can remain high for months or even years. To briefly mention IgA, which you might read about in some papers, this is produced in the mucosa. It is a specific antibody for the mucosa. Now, there's some critical aspects to this. And the first aspect is the quality of the antibodies. Do the antibodies neutralize the virus? And do they prevent it entering the cells? And you see that little drawing that I've got on the lower right. It shows antibodies binding to different parts of the virus. If they bind to some parts of the virus, it might have absolutely no effect on protecting you from the virus. It might simply bind the virus, it does nothing else. But if it binds certain parts, for example, of the spike protein, it might prevent that protein binding to cells through the angiotensin converting enzyme receptor, and therefore prevent the virus getting into cells. This is what we refer to as a neutralizing antibody. The second critical aspect is the quantity. How much antibody is there? As we'll see in a moment, some people produce high titers and some people produce low titers, and we don't know how many or how much antibody is required. And the third aspect is duration. How long do they last? For some diseases, the antibodies stay around only for a matter of weeks. For other diseases, they can stay for decades. And finally, a very important component consideration is antigenic stability. Does the virus keep mutating? Because if the virus mutates and it's no longer recognized by the antibodies, then your antibody defense is no longer effective. Next slide, please. So what do we know about the immune response to the SARS coronavirus 2? First of all, patients who recover from infection have antibodies to the virus. So that's good. Most COVID-19 patients develop antibodies sort of start about day 10 and peaks around about day 15. And this happens to coincide also with the time when many patients start clearing or clear the virus from their body. However, it's also worth noting that the titers, or the levels of the neutralizing antibodies, are higher in patients who had more severe disease, and that patients who had mild disease or asymptomatic disease tend to have low or non-detectable neutralizing antibodies. Please note, I'm saying neutralizing antibodies because we don't yet know whether this applies to all antibodies. But the neutralizing antibodies, we think, are what is required to clear the virus from the body. So in patients that had low titers, it's possible that it was the innate or cellular response that cleared the virus. And we've also seen this in another related coronavirus, MERS coronavirus. Patients who recovered with mild disease had low antibody titers and a high CD8, that's a cellular response, while those that had severe disease and recovered later on were shown to have high antibodies and a low cellular response, suggesting that the cellular response plays a critical role in clearing the virus rapidly from the body and not requiring a high antibody response. I must emphasize for the moment that most assays do not differentiate the quality of the antibodies, that's neutralizing versus non-neutralizing. The rapid point of care simply tell you there's antibody there or not, and ELISA can inform on quantity, but for the moment, most of the ELISA assays can't inform on the quality. Next slide, please. So this now brings us to the reason we're here. Will antibodies protect? Well, this simple answer for today is we don't know. So what do we know? For many virus infections, if you recover, you are actually protected from either getting reinfected, or when you get reinfected, it will be a mild disease. And this protection comes from antibodies, and it comes from the memory cells, the B memory cells and the T memory cells. Now, some caveats. This may require that you have high titers, and it may require that the antibodies are of an appropriate quality, able to neutralize the virus. For some viruses, we know that protection continues even after antibody has declined and we can't detect antibody anymore. And that is because of memory cells, the memory B and T cells. These will get reactivated when you get reinfected. But also we know that changes in the virus sequence can make prior immunity less effective or even useless. And influenza here is the classical case. Now, what do we know about other coronaviruses? Let's begin off with the seasonal or the endemic coronaviruses. We've learned about this last week. There are 4 of these. And we now know that if you are infected with one of these 4 or all of these 4, you achieve short-term protection against them, but you can be reinfected with these seasonal coronaviruses, and reinfection can happen pretty quickly. A paper has just come out, the reference is at the end of this presentation, suggesting that reinfection can even happen within 4 weeks. Now, others have suggested that there's some protection a year later. And others have seen that if you've got high neutralizing antibodies against these viruses, you are less likely to develop symptoms than if you have low neutralizing antibodies. But the question we have is, are these endemic coronaviruses really relevant models for COVID-19? Now, for the emerging pathogenic viruses, that's the MERS, the SARS, and COVID-19, we do not yet have enough data to confirm that antibodies protect, nor what titers are required, nor how long these antibodies will last. I will mention that in the case of MERS and SARS, antibody titers appear to last several years at least, but the outbreaks of MERS and SARS were of such short duration, we have no possibility of knowing whether these antibodies would have provided future protection. Next slide, please. So what does a positive antibody test tell us? Well, it tells us that the person was infected in the past with SARS-CoV-2. Now, caveat there, the false positives can occur. Depending on the assay specificity, that positive response might actually be false. If we have IgM and IgG, it suggests that the infection was recent, within the past few weeks. If it was IgM negative and IgG positive, it suggests that the infection was more distant, several weeks at least. What it does not tell us is if the person has recovered. So they could still be infectious and have a positive antibody test. They can possibly be persistent infection. It does not tell us if the antibodies are neutralizing unless a specific assay was used. And it doesn't tell us what the titers were unless we used an ELISA. So for the moment, and until we have more information from studies to determine whether antibodies do protect from subsequent infection, it does not tell us if the person is protected, nor for how long they are likely to be protected. Next slide, please. So what does a negative antibody tell us? Well, again, not a lot. It means that either the person has not been infected, or could mean that the person has been recently infected, less than 8 to 10 days, and we don't have antibodies yet. Or it could mean that the person was infected but cleared the virus without mounting an antibody response. For example, if they cleared it through an innate or cellular response. Or it could mean that the antibody titers are below the level of detection of the test. It does not tell us that the person is susceptible to infection. Next slide, please. So this is my last slide. What really then are the next steps? Because I'm afraid I've said there's a lot we don't know. We require more evidence about the effectiveness of antibodies following infection to guarantee the accuracy of an immunity passport or risk-free certificate, which would be based on an antibody test. I think many of us, most of us, are really hopeful that the evidence will support this. But for the moment, all we can say is we don't know. I will stop there, Sarah, and hand it back to you.
Thank you so much, Martin, for a very valuable deep dive into the immunity response that I'm sure was a lot of information for people to try and understand the science behind some of the recommendations that are coming out of WHO. I'm now going to hand over to Sylvie next to me to speak a few words about this concept of the immunity passport.
Yeah, thanks a lot, Sarah, and thanks a lot, Martin. It was really a great presentation. No, it was just to introduce a little bit what we would like to achieve with this webinar. It's really first discuss the science, and you have been very eloquent on this, Martin, but also go a little bit more to the public health rationale for this discussion, because indeed, in many countries, this concept of immunity passport or risk-free certificate have been discussed in a very specific context, which is the context of that many countries have put in place lockdown measures, and there is a willingness also to move out of this situation, release little by little those measures, and find a way to do it in a safe manner, meaning that we want to reduce as much as possible the risk of seeing a new wave of infection. And so many countries have looked at, okay, what are the things we can do to resume nearly normal life, or the new normal, but at the same time do it in a way that we are not going to see a new wave of infection and of course death. And so that's why this immunity passport or risk-free certificate is also to be understood in a context, social context and public health context that puts it from a different angle. And so Martin has given us the immunologic basis for this passport, but I think Andreas will give us now a more the public health perspective on this passport and how countries are dealing with those issues of returning to a new normal. Thank you.
Thank you, Sylvie. Andreas, I'd like to welcome you now to share some thoughts with us. Over to you.
Thank you very much. Yeah, a great presentation, a lot of food for thoughts, and I think it makes clear that we still might have some time to think of how to deal with the passports, because I think the evidence on immunity still needs to become much more clearer before we really can go there. But that's good, because I think it requires quite some thinking to get it right, how to deal with this immunity passports. So I think it's not a new concept if we think about it. Yeah, we have something like this for vaccine preventable diseases. For example, for measles, if we are already documenting in the vaccination cards sometimes for people in the healthcare service, for example, if they have titers for something, and decide on that where they can work, for example. So I think from the concept, it is not new, and therefore I also think it is realistic and good to think how it can be used for Corona. And like we heard before, I think it's really to tailor these relatively strict measures to the needed level in a way, and to prevent hardship for those who might not need to be influenced by the measures. And I think once we have this concept available, and also once we have evidence that there is a protection, I also think that even legal challenges, the courts will judge quite different about the measures if there are signs that some people are protected already and would not need to undergo these measures. So I think we have to deal with that. But for me, as the concept is not new, I think for me really what we have to think about now, also from a public health perspective, are really three main things. One is the immunity question. I think Martin elaborated quite nicely on that, and it's clear we don't know yet, so we are not there yet. The second is the test quality, and really having tests available that are answering exactly these questions. I think we are also not there yet, what Martin also showed nicely. But then I think the third thing, and this is something that from a public health perspective we really should think about now, is more the whole ethical, societal impact. And there, I think we really have to think of if we have these certificates at some point, who do we test? Is there then, does there have to be a right for test? Because if you are immune, you would be excluded from heavy measures. There might be the need for really a right to be tested, which is interesting thought. And also, do we have enough tests again? That's another question we have to address that. And the whole issue about how does that impact the compliance with the measures in a way, because you can only, because this is now the first time where such an immunity passport would not be based on the available vaccine. So you have a decision, you can protect yourself. The only way at the moment to get immunity is to be exposed to the virus. And that means you might have an incentive in not complying with the measures. And I think this is really something we have to think about now, how we deal with these questions. So I think it's clear we are not there yet, but these ethical questions we have to deal with now, because they will be very, very important once we are at this.
Thank you so much, Andreas. I wonder, Martin, whether you wanted to comment on some of those ethical questions. I guess sometimes they have been raised before in your area of work. Martin.
Sarah, you wanted me to weigh in on ethical questions? I think, you know, this is good.
Shall we move on quickly? Or?
I would suggest we move on, because I'm just going to say that while the science is imperfect, then it really comes down to ethics and taking risks. The moment the science becomes perfect, I think the risks will be significantly reduced, and then ethics becomes simpler. Over.
Thanks, Martin. Sylvie, over to you.
Yeah, no, and thank you to both for your very nice inputs into this issue, which is actually a very complex issue, not only because the science is not here, but there is some pressure indeed to have things change. And especially in many places, we would like, for instance, that healthcare workers who have been infected can go back to work and make sure that they will not infect the patients, for instance. So there are needs also to, I mean, just to maintain the health system working, to have those kind of certainty about the risk we are facing. And in some countries, and we have different data on this, but in some countries, the percentage of healthcare workers affected, I mean, among the total of patients is between 10 to 13%. So it's quite a high number of cases that are seen in health workers. And so it could represent a significant risk for the health system if people who are maybe are still infectious resume their work. So it's important indeed to have some ways to clarify where is the risk, what is the risk, how much risk there is, so that better decision can be made. There is also another aspect to the problem, which is really the issue of stigma as well. Because clearly now we have in a population two types of people, or three types. The ones who are probably safe, no virus, the ones who are currently hosting the virus with or without symptoms, and the ones who have cleared the virus and are somehow immune and therefore even safer than the ones who are not currently hosting the virus. So, and these categories of individuals, depending on the context, the culture, are seen very differently, actually. And to give you an example, it's, for instance, taking again the example of health workers. In some countries, at 8 o'clock every night, health workers people are clapping for the health worker, being very grateful for them because they are providing care, and regardless of their infectiousness. I would say, while in other countries, we have seen healthcare workers being attacked by people in the street because they are more exposed to the virus and maybe likely to have the virus, and therefore they are seen really as people that can be dangerous. And indirectly, also people being infected or having been infected can be seen in certain contexts not as a victim of a disease, but really as people spreading the disease, or being responsible of a number of deaths indirectly in their surroundings. So the perception of infection, non-infection can vary a lot depending on the culture, the context, and the way the virus and the disease is seen by the population. Another aspect of the discussion could be also about the issue of certificate or passport. And as you know, as for any certificate of passport, in certain contexts as well, you can have also counterfeit passport or certificates. And so it may also have repercussion in other contexts in terms of corruption, black market of certificates. And this is another aspect of public health that is not necessarily what is being discussed currently, because as you rightly said, we are not yet there and the science is still not yet there. But again, we need also to anticipate that those issues may come at some point in time, and how are we going to address them and mitigate the risk regarding that. So I think this was just to add to the discussion, and I'm sure that the audience will have many more questions or inputs into this debate and this discussion. But really, the stigma, the counterfeit certificates, and as you know, and the other ethical question that you raised, Andreas, I think these are things that we need to look at. Thank you.
Thank you, Sylvie. Andreas, is there anything you'd like to respond on those points raised by Sylvie? Sorry, I think you're on mute at the moment.
I try to do that, but then I forget.
Thank you.
Yeah, no, I was thinking about the false certificates, and of course that's always a problem with all the certificates in a way. And I think in many countries we kind of rely on just a document, and in a way we believe if a doctor has signed it and stamped it, it's true. I think it will be very difficult to overcome this as a problem in a way, because in a way we have to trust it, but that will create some problems. I think some countries are already thinking about electronic certificates as well. Yeah, and I mean, for some parts of the world that's an opportunity, I think, but there of course we even have to be more clear and sure how we do that, and I think there we're facing even maybe more problems, or at least concerns in different populations. But that's definitely a huge topic to tackle as well.
Thank you very much. I think just also on the issue of the ethics surrounding the concept of the immunity passports, there is a team at WHO who have convened a working group to look into this, so that some of the issues that we raised on the call can be adequately addressed. So that is work that's ongoing here at WHO. I think the importance of the potential fake immunity passports and the unintended harm that could potentially arise from that also links to another question that we received from in advance of this call, which was, do you see that the issuance of immunity passports would compete with the compliance of public health and social measures? Andreas, do you have
I mean, I scratched that already before. I do think it will, because I mean, it's already now I mean, you see in the population that they are less likely developing severe symptoms. I think there's already now in the countries that have not a very strict lockdown, you can see already that they're a little bit less following some of the rules, a little bit less concerned about themselves, and I think if they're just alone the fact that they think they are less vulnerable already now is colliding with the compliance. If we imagine now they even have an incentive out of that, I definitely think this is a huge issue. But having said that, I think this is just something to consider. I still think we cannot ignore the possible future fact that there is immunity at some point, and that people no longer need to follow these strict reduction of their personal rights. I think really every court will catch that if it's unproportional, these measures. And I think once you can prove that you are no longer affected in a way, or that you are not contributing to the distribution, which I think is another point we should discuss, then I think this will be legally much more difficult than it has been now. So despite the fact that we have issues there, I think we have to acknowledge them and address them, but I think we will not get around having these certificates at some point.
Thank you. Martin, anything from you before we move on to some of the questions?
So thanks, Sarah. I'll just really give a counterpoint to Andreas's final thing about the liability question there, that courts are going to, since you're on camera, I'll go on camera as well. Courts are going to say, well, these people are not dangerous, therefore they should be allowed to move. Well, there's the other liability issue, that if somebody has a certificate before we are absolutely certain that this antibody protects you, and they then become sick, or they then transfer disease to somebody else, there is also that liability. So once again, I think the science has to be driving this, but fully cognizant of the human aspects which have to follow immediately afterwards.
But I think we are completely in line there, Martin, because all my discussions are really after the point that science has kind of proven, or is so solid, and evidence is so available that we really can trust the test and the knowledge on the immunity. I think unless we have that, we should not go there, because all the questions that are coming there are even making the whole thing more complicated. But I think we should prepare already for the questions that are coming then, because they are difficult to solve. But I'm completely right. We should only start that when we are really sure it's working, the tests are working, and we know it produces proper immunity.
Thank you. Yes. So I think perhaps a spanner in the works would be if the virus does show some sort of mutation. We have a number of questions coming up about the status of what is the science at the moment telling us for COVID-19 and the rate of mutation. I know Andy is probably aware of some of the science, and perhaps Martin too. What do we know about the mutating virus?
I'd like to kick the ball towards Andy, because I have not been monitoring the impact of the mutation on antibodies, but maybe Andy can weigh in.
Over to you, Andy.
Hi there. I'm afraid I cannot add much more to that either. There was a report that came out of China some 6 weeks ago, describing two separate strains of the virus, but this paper was retracted shortly afterwards. I don't know of further developments on that. Thank you.
Sylvia, are you aware of anything?
Well, I know that there are, again, different strains, but what I don't know, and I don't know if anybody knows actually, what does it mean in terms of immunity as well, because we have, for instance, in flu, we have seen different clades of the virus, but it doesn't necessarily mean that, I mean, those differences have an impact on the response, immune response to those viruses. So I think this is a problem we have currently. We still don't know enough about this virus to draw conclusion on this issue.
Thanks, Sylvie. Another question that came through is, are we able to classify certain types of immunity, as in, would one type of immunity be better than another? Looking ahead to a potential time when there is a vaccine, would natural immunity from a natural infection be better than immunity from a vaccine? Martin.
Very difficult question. All types of immunity are useful. Most of the vaccines that we are that are under development are focusing on an antibody-mediated response to try and induce antibodies that will bind to the virus and prevent the virus getting into cells. There are a few out there that are working on the concept of a cell-mediated immunity, trying to establish a CD8 response or even just a CD4 response. And we've seen some reports in the newspapers over the last several days about people using non-specific vaccines to enhance the innate immune response. Now, it is clear that the innate immune response plays a really important role. And so anything you can do to get your innate immune response better off is probably going to be good. And that's probably going to involve around having a good lifestyle. But between the cellular response and antibody response, I think let's see which ones work.
We wait and see.
Maybe any question?
Yeah.
Yeah. And I just have, Martin, a question for you, because I've seen some people reflection about the fact that maybe if kids are showing much less symptoms than adults, it's because they have a stronger innate immune response. And that also this is, and they are not having necessarily antibody mediated response because because the innate immune response comes first, so they don't need to clear the virus to develop this antibody response. And what do you think about this?
Okay, well, let's begin at the other end of the spectrum. So old people that are older than me, tend to get more severe diseases. And we know that old people who are older than me, their innate immune system is beginning to get weak. This is a well-known fact. And we see this with other diseases. We see this with influenza. We see this with RSV. But when we come specifically to children, clearly they've got, first of all, they've got a strong innate immune system. You can see this. When they get an infection, they get fever very quickly. When an old person comes to hospital with appendicitis, frequently there's not even a temperature. So this is a function of the innate immune system. So children have a strong innate immune system, and this will first of all reduce the number of viruses that actually get into the lung. Let's assume that the infection begins in the nose or the eye. The innate immune system will reduce the number that are able to get down into the lung. So this gives them a huge advantage in terms of getting their immune system up and running before the virus starts becoming dangerous, shall we say. The issue, though, is between children and adults that are younger than me, because they should have a good innate immune system. How come the adults are also getting some severe disease? And I think there are a lot of complexities there. First of all, we've seen that people with underlying diseases, so obesity, these people have a pro-inflammatory response all the time. This is a constitutive interleukin-6 situation. People with diabetes, people with kidney failure, kidney problems, people with cardiac problems. A lot of these people have a pro-inflammatory system in which their innate immune system is already not going to be functioning properly, and then they're going to have a delay in their response to the infection. So kids are lucky because they don't have any of this. And also they've got a lot of energy. So whereas at my age and above, we don't have the energy anymore. Over.
Thanks, Martin. We've had another question that's come in. Is it likely that COVID-19 will become less virulent and transmissible over time as passed through many infected persons, as with SARS? Do we know anything about that? Speculation, I suppose, at the moment.
I will ask the others. I don't have a crystal ball.
We don't know. No,
we don't know. Time will tell.
Yeah.
Okay. I think we've had a number of other questions come through. I think you've answered it in part, Martin, and that is the link between the role of the immune system and severe disease. Could you perhaps just reiterate quickly a synopsis of that?
Well, we don't have an absolutely clear picture, but certainly if you are able to clear the virus immediately, or a large part of the viral challenge immediately through your innate system, that's good. If you then mount a cellular response rapidly and effectively, that's very good as well. If you still have a high viral titer when the antibodies are beginning to be developed, there appear to be two outcomes. One outcome is the antibodies clear the virus, and then you leave, you stand up, you walk out, and that's good. What we are seeing are a few percentage of the people that go on to develop a very severe disease. And we do not know what the role of the immune response is in driving this pathology. There's several hypotheses out there, but for the moment, we don't know that it is driven by the immune response. What we know is that the cytokines that are initially produced in the innate immune response and then they can become exacerbated and blow up as the immune system tries to fight the virus and is not succeeding. These cytokines can potentially cause more cells of the immune system to come to the site of infection, maybe the lung, and this can be pathological. We don't yet fully understand which cells are driving this and how to overcome that. Over.
Thanks, Martin. Another question with regards to the antibody testing. Aside from once-off testing, would there be a role for periodic antibody detection testing to be used to assess the exposure risk, particularly with regards to populations that are at high risk of exposure?
Sylvie, I'm going to send that back to you. I think you've got a better view.
Yeah. Well, in fact, what is currently very difficult for, I mean, of course, we try to look at the future and see, okay, how are we going to deal with this disease in the future? But currently, we are still struggling with, first, a very limited number of tests in many countries in the world. As Martin alluded to, I mean, even if now we have more and more commercial tests, I mean, their quality or their the interpretation of the result is still being discussed and not completely sorted out in many contexts. So we are really at the beginning of an outbreak and a new disease, and it started only 4 months ago, actually. So already we do have it's in the century, for many of us, because we have been working so hard, but actually it's a very short period of time, and many questions are still unanswered. And so currently we are still dealing with this disease by doing PCR testing and trying to find the virus as the best way to say if people are infected or not. The fact that now we have the serology in some instance helps us to have another perspective on the disease and the immunity as well. But still, we are still at the beginning of this problem, and frankly, it's worth asking the question now, but unfortunately, we don't have all the answer now.
Thank you, Sylvie. We've had another question about the validation of the rapid antibody tests. Is it true that none have been validated to date? And if so, they couldn't even be used then anyway for immunity passports? Martin?
I will send that once again. Sorry, back to Sylvie. I think
as far as I'm aware, I think they've been validated, but only not validated, but approved for use in research settings only. Is that correct?
Yeah, because again, as long as we don't know all about the immunity the immune response against this disease, I mean, those tests are interesting, but requires really to have a lot of observation before really saying this is what is needed. And so for the time being, this is what our colleagues from the diagnostic side are telling us, is that it's more prudent to use them as research and still make sure we can validate the results and also assess I mean, their efficacy and effectiveness before really going to a wide use and base policy on those tests. So I think we need a little bit more time for this.
Thank you, Sylvie. We've had a number of questions about ensuring that we can support the innate immune response. Martin, what do we know about general ways to support the innate immune response?
Okay, we risk leaving the area of science here. As I said, children, people, adults that are healthy, their innate immune response should be fully functional. What are the things we know damage the innate immune system? Well, I've already mentioned the diseases, diabetes, obesity, kidney problems, cardiac problems. Anything which is causing oxidative damage to the body tends to do this. There was a publication that came out a few days ago which mentioned that some athletes, shortly after performing high-intensity sport, also have a window where their innate system is temporarily reduced. We also know from the literature that lack of certain nutriments, things like certain vitamins and certain oligoelements, if you have a shortage of these, it can reduce your innate immune system and require more time for the body to respond. So how do we look after our innate immune system? Well, we stay healthy is the first thing that you do. But I think I'll stop there because otherwise we go into non-science.
We stay healthy and young.
If you can answer how to do the second part, please let me know.
Okay. I wondered whether, Andreas, you would like to share with us a little bit about the discussions that have gone on in Germany regarding the concept of immunity passport and some of the decisions going on there.
So I think that the German government is preparing, at least for the possibility to use these passports. So this week, the government has passed a cabinet proposal that is amending the Infection Act, and there it adds to the chapter on vaccination certificates. It also adds a chapter on immunity certificates, and has several aspects there that are very similar to the ones that we know for the vaccination certificate, with the name of the disease, date of the issue, test method. And then what is interesting, of course, and that was mentioned also in some of the chats I follow, the likely duration of immunity according to science. And this already underlines again that this is more something for the future when we have this information and knowledge available. So the reports on this proposal now are really making clear that the government is just preparing legally for the possibilities in the future, but it really makes it very clear that this only will work and applied when the science is there and the recommendations there as well, and from WHO and other partners there as well. But as I said before, I think we need already to prepare for that, and therefore I also think it is good to have the possibilities and the legal setting in place, but that only will kick off once we have really the evidence and the certainty. And I think just having it as a possibility in the law doesn't mean there is a pressure to use it as well. It will be, I think everyone is there wise and strong enough really to wait before the evidence, or till the evidence is there.
Thank you. So we're waiting for the science, but preparing, and I think that's the same as the discussions around the ethics. So taking into consideration all the ethical issues that could potentially arise. So Sylvie, I believe, has another question.
Yeah, it's a question for you, Martin, because it's not completely linked to the immunity passport, but it's more about immunity in general. And as you know, in the social media, there is a lot of concern about, or a lot of discussion about, and maybe this is a rumor, but about the fact that some people say that when you have been vaccinated against flu, this year you are more likely to get severe infection to COVID-19. So can you talk a little bit more about the immunity due to vaccines and the cross immunity maybe, or reactions? Over.
Let me answer that one first directly. So there was a publication that came out, it was written in 2019, came out early, 2019, came out early this year, from a group that looked at the vaccination of the armed services and their families. And they noticed that the group that received the influenza vaccine actually had a higher incidence of the seasonal coronavirus infection. So that their conclusion was picked up by people who say, oh, if you get the influenza infection, you're at higher risk of coronavirus. Well, first of all, this was the seasonal coronavirus. But when you actually look at the data, the people that were getting the influenza virus infections were the children, not the adults. And guess who gets the seasonal coronavirus? Well, it's the children, because they're going to daycare, they're going to school. So this was an observation. It was a correct observation, but the design of the study meant that the conclusion was not correct. But unfortunately, that was picked up by people, and then people just ran away with it. So it's very strange seeing in the social media people saying, oh, influenza vaccine is going to make you more susceptible, but BCG vaccine or polio vaccine or MMR vaccine or something else is going to protect you. I mean, either the vaccine, the innate immune system enhanced by the vaccine protects you, or it makes you more susceptible. So what do we know? Vaccination with the influenza vaccine protects you against this year's circulating influenza strains. It doesn't protect you against next year's strains. Might not, because we don't know what next year's strains are going to be. And the influenza vaccine doesn't protect you against coronavirus, but it doesn't make you more susceptible to coronavirus. So what it does do also is it stops you getting influenza. So it stops you going to hospital with symptoms that look like coronavirus, where you might catch coronavirus while you're at hospital getting checked out, or you might detract healthcare workers looking after you and your mild influenza and preventing them looking after people with coronavirus. So get the influenza vaccine and don't worry about it interfering with coronavirus. Over.
Thanks a lot.
Thanks, Martin. I believe we're almost at time, so I think we're going to just pass around the panelists to make a few closing remarks. There's been a lot of interest, particularly on the ethics. So I think as a follow-up, we could potentially invite our WHO colleagues who are working on the ethics side of things to enter into a discussion with us on a follow-up webinar. And in the meantime, we will collate the questions that have come in during the webinar to guide us in how we can address some of the topics on a follow-up webinar. So before we end, Andreas, would you like to make a few closing remarks?
I think most have been said, so I think it's a really important discussion, as with many topics, right, with COVID-19, like Sylvie was saying. I mean, we know as much as we've never known about a new disease in such a short time before, and we still seem to have more questions than we had before. So I think this is kind of our destiny that we have to deal with. But we try as good as possible to work through them and try to be a little bit ahead of the wave that is coming, both from the consequences and the epidemiology. And I think this is one of the puzzles to discuss about this immunity and how to use a possible immunity, also to inform the measures better, really to tailor it better to control such an outbreak like with COVID.
Thank you, Andreas, and we're very happy that you were able to join us on the webinar today. Martin.
Okay, well, I maybe just finish up with just a few thoughts. We watched with Ebola that we had a lot of deaths, and at the end of the Ebola outbreak, we still didn't really know how this virus kills. What is the response to the virus? We saw this was similar with MERS and with SARS, that at the end of the outbreak, we hadn't learned a lot. So I really want to just make sure that while we are seeking vaccines and treatments, we don't forget learning what this virus is doing, how it's interacting with the immune response. And so this, I think, is a whole separate research arm. And I worry that not enough attention is being given to this. So just to encourage people to focus on that as well. Over.
Thank you, Martin. Andy, anything from you?
Thank you. No, this has been a very rich discussion about an area in which we are still learning a lot, and much remains still to learn. So a very interesting field as we go forward. And I've been watching the questions rolling in on the Q&A section here. Some very, very interesting, very thoughtful questions in there. Thank you.
Thanks, Andy. Sylvie?
Yeah, so I would like to thank you all for attending this discussion, but also Martin and Matthias for joining us. I think having different perspectives is really useful. And as we said, the science is evolving, and people sometimes are a bit upset because they feel that we change our mind. We say something one day and something different the next day, but actually it's just because knowledge is accumulating. And something that we thought was right a few weeks ago happened to be not so right. And I think it's very important that we accept that science is a process of building knowledge. It's a never-ending process. Actually, you can always learn more and have more insight into what is going on in nature, and especially with viruses. And I think what is really important with those discussions we have here is that we try to make the science within something useful for our own lives, and science to help for decision, not only to know for the sake of knowledge, but really knowledge to help us to have a better life. And I think this question of immunity passport may have a lot of good implication as well for our social life, of the way we are going to live with this disease in the near future. And I think it's very important if science can be always at the core of it and help us to find the right direction. So thanks a lot for your insight, your thoughts, and your science.
Thanks, Sylvie. We've had a lot of requests for Martin's presentation, so I will share that along with the link to the recording of the call within the next couple of days. So thank you again, everybody, for attending, and I wish you a peaceful weekend.
Thank you.
Bye-bye.
Bye.